on the screen. 2, please use the Q&A box at the bottom of your screen to send in questions, as well as communicate with the event host throughout the presentation. And finally, we will hold a Q&A session at the end of the presentation. If you can also please clear away any distractions, that would be wonderful. The Institute is proud to provide this free community lecture. We have multiple clinics throughout Orange County. Our main clinic is currently located in Costa Mesa off of Bristol. And we also have integrative services at other UCI Health sites, including Newport Beach near Fashion Island, the Pacific Medical Plaza in Costa Mesa, Yorba Linda, and our newest location in Laguna Hills. Now on to the main event. Dr. Shalini Shah is a board certified and fellowship trained UCI Health physician who specializes in the management and treatment of adult and pediatric pain. She has extensive training in chronic pain disorders in children, specifically oncologic pain, head and neck pain, abdominal pain, scoliosis, and spasticity disorders. She earned her medical degree at St. George's University School of Medicine in Granada, and she completed a residency in anesthesiology at Weill Cornell Medicine and New York Presbyterian Hospital in New York City, followed by a fellowship in adult and pediatric pain management at Brigham and Women's Hospital and Beth Israel Deaconess Hospital, as well as the Children's Hospital of Boston. There she trained under Dr. Charles Bird, a world authority in the management of pain in children. Dr. Shah has a particular interest in alleviating chronic pain conditions with a multidisciplinary and interventional approach. And her goal is to reduce pain so that children and adults may reclaim their lives and return to the activities they previously enjoyed. Please join me in welcoming Dr. Shalini Shah to this evening's Integrative Insider Live.
Thank you, Dr. Heck, for that nice introduction. I'm so happy to be here with everyone today to talk about innovative options for pain control. There are a plethora of options available, and I know pain is a big item for many of us who suffer from chronic pain. So I like a very interactive format. So if you would like, please include your questions in the chat format and in the chat function, and we'll be monitoring them periodically, and I'll be answering them periodically. So I'm going to share my screen and get started. Okay. All righty. So yes, my name is Shalini Shah. I'm the Director of Pain Services for the UCI enterprise across the whole hospital and health system. And so in this role, not only do we manage acute pain, but also chronic pain, both in our ambulatory clinics as well as in the hospital. So when you're hospitalized for pain, you do have 24/7 access to a board-certified pain physician. One of the big things that most people don't know is that most people who are living in pain have actually never seen a pain specialist. And what does that mean? That means about 19 million people in this country have high impact pain, which affects their quality of life functioning on a daily basis. And most of these patients really have low back pain. In fact, the Institute of Medicine predicted that about 1 in 3 Americans have chronic pain in this country, which is not a small amount. So at some point, we will all develop some types of pain. And the most common typically is low back pain. Part of it is from the degenerative process as our bodies age and we grow older. But a lot of it can be prevented, believe it or not, from a lot of the options that we have that are really not rocket science, but sometimes people don't hear about these options. So as a result of the large amount of patients that are suffering in chronic pain, the HHS, the Health and Human Services Task Force, created a guideline, which is a final report on the best practices for how pain should be treated in this country. And you can see the bulk of the starting point should really be medications, which are either opiate or non-opiate options. And this includes a lot of the integrative options that the Samueli Center offers, and we'll get into that. But also restorative therapies such as physical therapy, diet, exercise, things like that. Then if that doesn't work, the next thing on the paradigm is our interventions, and I'll explain to you what that means. But in conjunction with that includes a behavioral health approach, complementary and integrative health approach. So it's a continuum, meaning we attack pain from various facets. So let's start at the very beginning, okay? I would like to give, a general overview of what low back pain is and how low back pain can present, so you feel even more educated when you go to the doctor's office. So as you can see here, this is the spine. We're looking at it from the side, and various things can happen as we age. You can see down here, there's disc degeneration where the disc itself dehydrates, but the disc can also herniate out. And you can see that purple bulge. And that bulge occurs either when you're moving in the refrigerator, but it can also occur just by sneezing, straining during a bowel movement, benign things that we don't even realize. And what happens when a disc herniates is that it compresses the nerve that's adjacent to it, that's just trying to exit, as you can see in that red circle. Okay, so you see that nerve trying to exit, and that's how pain can present, typically down the leg. Another big way of causing pain as we age is arthritis. And unlike arthritis that we have in our hips and our knees, those joints can be replaced. But unfortunately, we're not at the point in life or in technology where we can replace the joints in the back. So we have to find ways to treat that pain that does not involve a hip replacement, a joint replacement. The final type of low back pain is the sacroiliac joint. This joint that you can see that's highlighted in red is actually the largest joint in our body. And not only due to age, but also from, pregnancy, obesity, things that occur to us as a normal part of life, these joints can also degenerate and cause pain. And typically this pain will be in the low back, off to the side, where the dimples are in the low back. That's where we typically see these types of pains. But I always stress to all my patients and to anyone really I meet, to be quite honest, most of the back pain can be prevented. And a big part of this is exercising daily. And I know it's hard, we're all very busy, but simple things that we can implement in our daily lives can make a tremendous impact in how we, or if we will develop pain later in life. A large part is exercising daily, but also practicing good posture, lifting correctly. And what that means is typically when we want to lift a box, we'll lift from the knees up and then turn. That's how we injure our back. It's the BLT, it's the bending, the lifting, and the twisting motion simultaneously that causes the disc herniation. So really making sure that we lift things properly, sleeping properly, and maintaining a healthy weight. Again, things that we've known for centuries, but sometimes very, very hard to implement. So what happens when we age? The muscular system is affected by aging in various ways. And let's go over some of that. So aging will affect our muscles. So you can see in the top picture, you see a nice healthy muscle mass, but as we age, the muscle mass decreases. And what's the function of that? A lot of it is due to the loss of elasticity and collagen as we age, but it's also due to the blood flow, which as we age, the blood flow decreases, and this decreases the nutrient supply to that muscle tissue. And couple that with aging, loss of collagen in our joints, plus obesity, you can imagine the stress that we put on our everyday joints. And you can see the loss of joint space on the right as a result of obesity. So what I'm trying to get at is that there's a plethora of things that happen, some that we see, like obesity, but a lot of things that we don't see at the microscopic level that causes aging and there consequently causes pain. So some things that we can consider is diet. If you've ever been to the Samueli Center, you know diet is a big part and parcel of not just treating pain, but treating all diseases. Increasing our protein, using a Mediterranean diet, supplements, and exercise. So let's go over that. Protein intake. In a study using evaluating nursing home residents that ate lean red meat protein, and exercised about 6 days per week, those patients had greater improvements in their muscle mass and strength as compared to those who had a high-fat diet. What about the Mediterranean diet? We hear a lot about that diet, particularly for pain. It's highly beneficial. So using olive oil, fruits, nuts, vegetables, a moderate intake of fish and poultry, low intake of dairy, and moderate intake of wine, ideally red wine. And what's the evidence for that? So in this study of about 5,000 individuals, so not a small study, who used the Mediterranean diet, those subjects had a decreased pain, disability, and depressive symptoms compared to those who did not. Turmeric, it's a wonderful, wonderful antioxidant supplement, but it's also a great anti-inflammatory. So for those of us who suffer from knee pain, knee joint arthritis, shoulder joint arthritis, hip joint arthritis, it's great to supplement. And believe it or not, the toxicity level is quite high. So unlikely with normal use, one can become use curcumin to a toxic level. There are a lot of innovative options for back pain, and I think that's one of the reasons why we're here today, to talk about what's out there. And one of the things that I love about this field, really truly love about the specialty of pain, is that there are new options coming out year after year to help treat pain. So the things that we typically think of, like cortisone injections, are really falling by the wayside, and a lot of new cutting non-steroid, non-permanent options, are non-surgical options, are really coming out to the forefront. So let's talk a little bit about the basics. The first thing is, anyone with pain, you should start into a physiotherapy program based on the recommendation of your physician. A lot of this is, to be quite honest, offloading those joints that are painful and teaching your core, meaning your other muscles, to strengthen so that it takes the pain, the pressure and the pain off the back. There are a whole host of medications, but unfortunately, medications, as you know, don't come without side effects. So I thought I'd put this little slide up, and I know it's a little bit complex, but it really points to how complex pain is. So imagine, you put your hand on your stove and you have a noxious stimulus. That pain signal from that burned hand goes to the spinal cord, up to the thalamus, and then ultimately up to the brain for perception. That's how we perceive pain. Depending on where that location, that nerve synapses, will tell us if it's in the hand, the leg, the foot, where that perception signaling occurs. But through this signaling, and I know I've oversimplified it, to be quite honest, there are multiple options to treat pain. Some of it are enzymes that we can use in terms of how we perceive pain. Some are transporter genes, so actually altering some using gene therapy to alter how we pain signals are transported. And then even our opiate receptors can have mutations in it, which can lead to why some of us need more opiate medications and why some of us need less. Speaking of opiates, it's a hot topic today. We went from about 10, 15 years ago from a culture of opiate philia, where we were prescribing liberally, to now understanding the long-term consequences, quite honestly, the societal downstream consequences of prescribing opiates so liberally. So what is it? What are the side effects with opiate medications? I typically tell patients that, like any medications, these opiate medications also have side effects. The biggest one is it can make you stop breathing, particularly when we take it in conjunction with alcohol or benzodiazepines like Valium or Ativan. So in an option to save us from using opiate medications, we do have a variety of pain interventions. And the good thing is, and this is what I typically try to tell my patients or any of my friends, quite honestly, the complications of many of these interventions are rare. You can see I have a study of nearly 400,000 nerve blocks. The nerve injury rate was only 0.04%, so not even 1% in terms of the risk. The risk is higher, though, in patients who use tobacco, so who cigarette smoke, who have diabetes, which is a big predictor of poor wound healing and high blood pressure. So now to the crux of the talk. What are these cutting edge options? So the first thing is, we talked about those joints that degenerate as we age, right? So there's a newer technology that was created about 15 years ago, and now it has been improved and improved over the last decade or two, in which we can actually burn the nerve that supplies those joints. Like I said before, the spine joints, we can't replace them. They're not like our hip and knee joints where we can get a spine replacement surgery. So we really have to find ways to treat that pain. And using a radiofrequency ablation, which means a needle that heats up and can deliver heat energy to those nerves, gives patients anywhere between 6 and 12 months of relief without having to use any medications or any steroids. So like I said, the active tip of the needle is heated up. And then we stimulate the nerve to make sure that's the nerve we want, and then use heat energy. Going back to the original diagram that I showed you in terms of how pain is transmitted, what are the options that we have to treat pain at those levels, to intercept the pain transmission? I could show you this slide. One of them is using electricity for pain relief. And believe it or not, the use of electricity for pain relief is not new. It's actually something that the ancient Greek scholars found just at the turn of the millennium. In fact, a lot of patients were suffering from gout. And what they found is when they would submerge their feet in a tiding pool with torpedo fish, which would generate electricity, those patients stopped feeling pain. So the treatment for gouty arthritis, back in the ancient Greek civilization was actually to submerge yourself in torpedo fish waters. And so this is an excerpt of an ancient Greek scholar demonstrating the use of torpedo fish and stimulation. So we have come a long way in 2000 years to take that finding, that phenomenon of electricity of a torpedo fish, and present it into a medical device. And this is called spinal cord stimulation, where a very thin electrical electrode is implanted into the body. It can be in the spine for back and leg pain, but it can also be in the shoulder for shoulder pain. It can be in the knee for knee pain, both centrally and peripherally, to modulate how the brain perceives pain signals. So like I said, it includes an epidural array of contacts, and you can see that electrode there, and then a remote control. So patients can turn up the energy if they want more stimulation, more electricity, on days that they're feeling more pain or had to do more activity, or turn it down on days that they're feeling better and just don't need as much electricity. Either way, you're delivering electricity to block the impulses, the pain impulses from reaching the brain. So the newest technology that I'm really, really proud to talk about is something that actually we're one of the first centers in Orange County and San Diego County to offer. So UC Irvine was the first center to actually offer this. It's really a cutting edge technology called peripheral nerve stimulation, where we take an even smaller electrode, really the size of the hair. You can see in the top left picture, the size of a hair, and put that electrode at the greatest pain generator. It's pretty complex and needs a very trained physician to put this in. But once it's in there, you wear the generator, you wear the electrode for 60 days. So it's not a permanent medical device. You wear it for 60 days. You can continue your activity as normal, take showers, do everything. The only thing that we restrict you is no submerging yourself in water. So no bathtubs, no jacuzzis, no swimming pools during that 60-day period. And the premise is that we're sending enough electricity to those nerves to reset them so they stop firing. And if you look at the data, about 75% of patients will actually have long-term, and long-term means 12 months, a year's worth of relief, even after the device has been removed. So keep it in there, keep that hair electrode in there for 60 days. You wear that little generator, which is the battery, for 60 days, and that's what delivers the electricity, that battery pack. And you also get a little remote control that you can wear or put in your purse and turn up or turn down, dial up the energy to what you see fit. The bottom line is the nerve gets 60 days worth of energy to reset it. So this is something that we're really, really proud of to showcase at our facilities and our clinics. And really, it's been a groundbreaker, especially for those patients who have MS or really debilitating type of pain where they have frozen shoulder, or for those patients who have aged and really don't have the ability to raise that shoulder, but really say to their doctors and say, look, I don't want to undergo surgery. I don't want to go, surgical procedure that requires healing, maybe a nursing home, and who knows if it works, if I have complications, infections, things like that. There are some patients who say, look, I've had a knee replacement and the knee replacement helped, but I still have about 25% of my pain that's still not relieved. So this is a really, really groundbreaking option for those patients who don't want surgery, don't want a permanent medical device, and can really help you rehab, get to PT, while you have that device in. So, but it's not for everybody. And I tell everybody that, comes to me and I say, that we really have to choose our patients carefully because not everything is for everyone. So these therapies that I just talked about are FDA approved for the management of chronic intractable pain for the trunks or limbs. Okay, so we're talking about back and leg pain, nerve pain, ischemic pain. So if you're a vasculopath, meaning you suffer from peripheral vascular disease, where your blood flow and your vascular system is not functioning as normal, and you have pain when you walk, this is a great device for you. Angina, so even those patients who have cardiac pain, who've had a heart attack, or who have heart failure and still have pain, even with a little bit of movement, this is a great device for you. And obviously for those patients who've had surgery, but still have residual pain. Who is it not for? And I like to put this slide up nice and bright so everyone knows. Like I said, not everything is for everyone. So we try to limit devices, especially permanent medical devices, for those patients who have significant psychological barriers. And that means significant depression or anxiety that really limits their ability to take care of a device, whether the device is for 60 days or whether that device is for permanent use. We really like to psychologically screen our patients, knowing full well that patients who have chronic pain, at some point, everyone will develop anxiety or depression. It's a known fact of chronic pain. And really, because chronic pain travels with anxiety and depression, so a lot of our patients who have chronic pain will develop anxiety or depression, and those patients who have anxiety or depression may also develop pain disorders. Patients who have bleeding disorders or are on anticoagulant therapy, we have to be very careful with. Patients who have infection or are prone to a high degree of infection, we have to be also very careful with. And especially those patients who have pacemakers or ICD, meaning implantable defibrillators, may not be the optimal patient choice. And immunosuppression. So those patients who take chronic steroids, or those patients with active cancer using chemotherapy, are typically immunosuppressed. Again, not a complete contraindication, but something that's relative that we really have to weigh in terms of risks and benefits. And this is the thing that I was talking about earlier, where we have a vicious cycle with pain, right? When you have pain, you don't want to walk, you don't want to move, you get deconditioned. And because you get deconditioned, you try to avoid activity even further. And because of that, now you develop some element of anxiety and depression because you're not doing the things you normally were doing. And that makes pain worse. And so this is really the point what I'm trying to say here, whether it's integrative options like diet and exercise and supplementation and all the things that we talked about, whether it's medications, whether it's all the cutting edge therapies that we discussed, wherever we are in the paradigm, one thing that we all know to be true is that early treatment is key. And I can show you study after study after study that shows early treatment of pain really is going to be the biggest differentiator, whether you live with pain short-term or long-term. So I wanted to show you a little bit about what we do here at UC Irvine. So you get to know us. We have about 6 or actually 7 sites, I would say maybe even 8 sites now, of pain clinics across Orange County. And this is really remarkable because when I started about 10 years ago, we only had 1 clinic, and that was at our Gottschalk clinic in Irvine. But over the years, we have really expanded to all over Orange County. And I really try to recruit doctors for you that have the cutting edge experience. And so all our doctors come from Cleveland Clinic, Harvard, Northwestern, USC, you name it. Our doctors are trained at Georgetown University. Our doctors are trained at the best of the best. And we try to recruit them heavily to give you the best options. And so you'll get the feel of the Cleveland Clinic way of treating pain here in our backyard in Orange County, or how Northwestern treats pain, or Harvard treats pain, all here. So these are different sites that we have. The latest one that we just opened up is in Laguna Hills. So that's the newest site. It's a really nice community fun site. Great parking, great feel when you walk in the center. It's just a family feel. So we see, I should have updated this slide. We have over now 21,000 patient visits a year. We have a neurologist in our clinic, a psychologist, a physical medicine and rehab specialist in our clinic. Like I said, we're all over Orange County. And so this is a little bit about us, of how you can contact us. It's very simple if you're interested in learning more. And really, you don't necessarily need to come in. We can do a telemedicine or a Zoom visit over the phone. And just, a lot of our patients say, I'm here just to learn options. Here's what I'm suffering with. What can I do? I don't necessarily want you to treat me, but let's go over what are the options. And you can learn a lot more on our website, ucipain.com. And we keep the numbers easy. So if you wanted to schedule an appointment, it's 949 UCI Pain, very easy. We don't use the hospital resources. We have our own staff in our clinics who you will talk to and can help schedule you anywhere in any of our sites. So it's a really nice family feel when you come to our clinics. So I'm going to stop there. And I really, I know I went through a lot of information, but I really want to open it up to questions and answers. And whether you're suffering from a specific condition or you just want to learn more about what we talked about, I think Q&A is such a great format, especially in these new Zoom visits where, you don't have to be embarrassed about going to a microphone to ask questions. So I'll stop here and take all the questions, which I see there's quite a bit.
Yes, there are a number of questions in the chat. Thank you so much for your talk. Yeah. And I wanted to just ask some basic questions for the patients. The first question is your therapy, this new device for peripheral nerve stimulator, covered by insurance?
Oh, great question. Yes, it's FDA approved. It's covered by Medicare and almost all insurance plan. I haven't seen any insurance plan really that denies it unless you're from out of state. So Texas or something else, then we have limited coverage, but we do, we can appeal it. So it's definitely covered by insurance and we'll work with your insurance plan.
Okay, and then do you have an estimate of how many patients you have used this device on in your clinic so far?
I want to say, the device is new, so it's only been FDA approved for about 1.5 years at the most. I want to say close to 50, maybe even more patients. Yeah.
Okay, so I have some questions like from the beginning of your lecture, and I can also help answer some of them as well. One of them was, what is the optimum dose of turmeric for arthritic pain?
Kim, you want to take this one?
Sure. So the dose that I usually prescribe to my patients is 1,000 milligrams. Some of my patients do take more. There's a lot of different forms of turmeric on the market. So one form that I am partial to is curcumin, which only constitute about 3 to 5% of turmeric. And so some of my patients that have more severe pain that they've already tried turmeric, they say, oh, they drink the golden milk, but they still have pain. I usually switch them over to a curcumin. And some of them are more bioavailable than others. I won't name any names on here, but about 1,000 milligrams. And then another question is, can peripheral nerve stimulation halt peripheral neuropathy in the feet?
Oh, I'm assuming you mean by stop. Pretty much no. So is it going to stop the neuropathy forever? No, because that's a molecular mechanism of what's happening there, and it depends on the reason for the neuropathy. Is it diabetic neuropathy, which is glycosylation? Is it something that's coming from the back? By the way, we will all of us develop neuropathy in our feet as we age. So if you're suffering from that, just know that it's normal. There's a lot of things that we can do, but it definitely, these peripheral nerve stimulators can help stop the progression and help deal with symptoms, which is really what we really need at that point. The peripheral neuropathy is typically, if it's mediated by bigger nerves, it's harder to treat that, but if it's a smaller nerves, we can do a pretty good job with that.
Okay, and then another question was, what constitutes sleeping healthy?
What constitutes, I'm sorry?
Sleeping healthy, because you had that in one of your
healthy
slides.
Sleeping. Oh, healthy sleeping. That's a good question. But just as a side, I don't know if anyone's following the news, how the House and the Senate are voting on eliminating daylight savings time, using what we have right now as the new benchmark of what our time zones will be and not using any more time changes. And the Academy of Sleep Medicine came out and they said, what we're in right now, where we have longer evenings, sunlight longer evenings, is actually detrimental to healthy sleeping. So using the previous version where we get up earlier and be able to do our chores with daylight in the early hours and less daylight in the evening hours is actually healthier in terms of healthy sleep. But healthy sleep is getting at least your 7-8 hours, and it's really different for every person. I can't function on less than 7 hours of sleep, but other people can.
We also have a sleep medicine clinic at UCI.
Yeah, I'm interested to hear about that, Dr.
Yeah, so I do have a lot of patients that suffer from insomnia, and I usually will send them to the sleep clinic in case they have sleep apnea. But if they have other behavioral issues that affect their sleep, we do have a cognitive behavioral program that's run by a psychologist, and they will look at your behaviors. So what you eat, at what time of day, when you exercise, all of those things actually affect your circadian rhythm. And through behavioral changes, they can help, support your sleep. And they actually give you they have you purchase a device that checks the quality of your sleep. So when you talk about the quality of sleep, there are a lot of devices out there that can check how much REM sleep you have, or how much deep sleep you have. So all of those things are a factor in healthy sleep. So you can't, yes, the amount of sleep is also there, but if you have apnea or you don't get enough deep sleep, those things will also affect whether you have healthy sleep or not. Another question was, do you have, Dr. Shah, do you have experience treating small fiber neuropathy?
Yeah, we see quite often small fiber neuropathy, particularly in the feet. We see it quite often, and there's a whole host of things that we can do. It's unfortunate, because I know how much patients suffer from it. Some patients even go so far as to get biopsies and things like that, but there's a lot of things. And Dr. Heck, do you know from the Samueli Center how many options there are? I think the biggest groundbreaking options, to be quite honest, are the things that the Samueli Center offers.
Yes, we have a lot of experience with small fiber, but honestly, it's a multidisciplinary approach. Like Dr. Shah said, yes, you may have small fiber neuropathy, but you also may have a pinched nerve in your back, and you may also have diabetes. And so, correcting your diabetes, working on your back, and then, looking at the different supplements that we recommend for neuropathy. I mean, the studies out there, are not as large as I would like them to be, but I have, had a lot of success. But what I see is, honestly, that I work hand in hand with Dr. Shah to correct different pains, because if you have sciatica on top of your small fiber neuropathy, all those signals are still being sent to your spine, and that causes central sensitization, and then you're going to be more sensitive to pain everywhere. And then this one says, does radiofrequency nerve ablation permanently damage the nerve, and what are the side effects?
Okay, good question. So the radiofrequency ablation is done on a nerve that the nerve's only function is to deliver pain signals to that joint. Okay, so it's not a permanent option, and the reason for that is because nerves do grow back. Nerves regenerate. The smaller nerves regenerate faster than our bigger nerves. So it's not going to be a permanent solution. And like I said, it's only for that small sensory nerve. It's not for any other nerve that has any other function in our body. And we do a lot of testing, believe me, before we even think about ablating, meaning using the heat energy to destroy the nerve. So it's on a very small sensory nerve. The nerve does grow back. How fast it grows back is determined by a whole host of factors, but it does grow back between 6 and 12 months.
This other one says, does your clinic handle patients with multiple chronic pain disorders like migraine, fibromyalgia, or POTS?
Yes, we have a huge population with POTS. We have a very, very big population of migraine, and quite honestly, a lot of options for migraine.
Like Botox?
Botox, exactly, for migraines. And then what was the other question? POTS, migraine, and?
Fibromyalgia.
Yeah. And this is again where we work really, really closely hand in hand with the Samueli Center, because integrative options and psychological options, and we have a pain psychologist, are really where we make the biggest impact with fibromyalgia. because, you know, it's such a debilitating disease and people do need a lot of support around them.
So back to the peripheral nerve stimulator. I know I've sent some patients there that have had very like specific areas of nerve pain. In your recent experience, like what have you seen to be the areas that have responded the best to the peripheral nerve stimulator?
Yeah.
Is it the frozen shoulder,
Yeah.
or, you know, or the knee pain even after total knee replacement?
I'll tell you, there's 3 things that we have seen that's really helpful for. And really, it depends on the person, but let me get into the 3 things first. Number 1 is the shoulder. So when it comes to shoulder pain, there's other injections into the shoulder joint, or there's shoulder surgery. There hasn't been typically much in between in terms of what we can offer patients. So this has really been groundbreaking for shoulder, because when the injections fail, when the steroids fail, and the PT fails, and you still have pain, you still have immobility of the shoulder, really getting this device in has been really groundbreaking. Because once you have the relief, you're able to do a lot more physical therapy than you would have had done previously if you didn't have pain relief. So that's one option. The second is the knee. Again, for those patients who had knee surgery or are contemplating knee surgery but don't want to undergo knee surgery, this is a great option. And the final one is, quite honestly, pelvic pain, which is something that not very many people think about, and quite more than that, not very many people feel comfortable talking about. It's you know, very personal to describe pain in the pelvis, whether you're male or whether you're female. And so this is really a good option for treating pelvic pain, which oftentimes is very chronic in nature. We've had patients go to 4, 5, 6, even had one who went to 22 physicians across the country just to get pain relief for his pelvic pain. And then we tried this device, and it really did help, quite honestly. So you never know. It's highly debilitating, affects your quality of life, not only with yourself, but also with your partner in a relationship. So these are the 3 things that we have found to be the best use scenarios.
And for our audience, can you also explain what most often you use a radiofrequency ablation for?
Yeah, so radiofrequency ablation is just a fancy term for using heat to destroy a nerve. And so what we typically do is for the low back, as we talked about with the arthritis in the spine. So this are our patients who are anywhere between 50 plus, who have started to show signs of degeneration of the joints, where they have this band-like pain in the low back. You wake up with morning stiffness. It hurts with, you know, any extensive maneuvers. Rotating that spine seems to cause pain. That's really how you know you may have signs of arthritis in the spine. And so that's when we use that radiofrequency ablation, the heat, to destroy the nerve. But that technology can be used elsewhere. So for those patients, for example, again, who had knee surgery, now still have knee pain, we can destroy those nerves that give sensation to that knee joint. Again, not permanent, it's a purely sensory nerve, so we're not knocking out anything else that you may need, but it's another option if you don't want to use a peripheral nerve stimulator, to use ablation. Again, 6 months to 12 months of relief until that nerve grows back.
I have one patient that comes to the pain clinic, and she's had tremendous improvement of her occipital neuralgia with the radiofrequency ablation. So she used to get, and she still gets headaches. I mean, she had a major car accident that left her with double vision. And the prism glasses help, but also like the biggest thing that she tells me all the time that really helps her to live her daily life is the nerve ablations for her occipital neuralgia.
So one of the biggest things in terms of, one of the things that we physicians look at when we evaluate therapies is something called the NNT data, the number needed to treat. So that means for one person to get better, how many patients need to be treated? So the lower number is better, meaning if I only need to treat 3 patients until one person gets better, that's better than having to treat 15 patients until I see an effect on one person. So that's called NNT. So if you look at the NNT data for a lot of the things that we do in pain management, exactly to Dr. Heck's point, radiofrequency ablation in the cervical spine for the cervical joints after a motor vehicle accident, whiplash accident, that seems to be the strongest NNT data. The most effective, one of the most effective things that we offer in pain is treating the cervical spine, the neck pain that goes to the back of the head, the neck pain that radiates to the shoulder. Those joints, when they degenerate, they cause a tremendous amount of pain, but are treated effectively with ablation.
Great. Well, thank you so much for taking the time this evening to join us.
Pleasure, my pleasure, always.
All right. Well, I have a few other things to say before we close. Thank you everyone for joining us for our Integrative Insider Live community lecture. Upon ending this webinar, a pop-up window will show up and there will be a valuable survey on this evening's event. Please help us improve our community offerings by letting us know what you think. We'll also be emailing 5 key takeaways and send a copy of Dr. Shah's presentation to the email address provided at registration. On Friday, May 6th, we are hosting our 20th annual Women's Wellness Day. And this event is an inspiring day full of thought-provoking and informative speakers who share tools designed to expand health knowledge with evidence-based practices and modalities, giving you clear guidance to help navigate your own well-being. We are hosting this event as a hybrid with a limited number of in-person tickets still available, as well as virtual options. So registration is on our website at sssihi.uci.edu. And we'll be announcing our next Integrative Insider Live speaker soon. So check your emails for information. Thanks again, and we'll see you next time.